reality is we are an indoor species. We're spending the majority of our time indoors. But if you think about where the research dollars are and what we spend a lot of our time thinking about, and even what we have protections for, it's that 10% of where we spend our time. We have national ambient air quality standards for outdoors. We don't have anything for the indoors. The outdoor air pollution actually penetrates indoors, so much so that the majority of your exposure to outdoor air pollution actually occurs indoors. I think a lot of people find that surprising. So the indoor environment is having a massive impact on our health. But if I asked you all to say, name the things that constitute healthy living, what are they? You'd say, I need to exercise, I need to eat healthy, outdoor air pollution is bad for me, I shouldn't smoke. And if I asked you how you know about that, you may not know, but the reality is most of what we know about healthy living is derived from these great human epidemiological cohort studies, follow tens of thousands of people over time, see what happens to them, look at their behavior, and we find these associations that largely tell us what constitutes healthy living. The problem is these studies ignore the role of the built environment in buildings, that place where we spend 90% of our time. So it's a glaring hole in our understanding of healthy living. That has changed a lot in the past year. The number one risk factor for this virus is time spent indoors. Then no masks and buildings with low to no ventilation. This is what's driving all the super spreading events. We know how to keep people safe in buildings. One of the key things we have to focus on is bringing in more outdoor air and cleaning that air a bit better. So we've set some targets for how much air exchange should happen. The ACH is the air changes per hour. And we recommend targeting higher ventilation rates, better filtration, and portable air cleaners. I want to talk about where we need to go. This is a slide showing the 100-year history of ventilation rates in buildings. The dotted line is a target ventilation rate for health. The blue lines with the dots are actually where our ventilation targets are. In response to the energy crisis in the late 70s, we started tightening up our building envelopes, choking off the air supply in our buildings, and we've designed our buildings for a long time now to be chronically underventilated. We've let engineers make decisions on ventilation rates in buildings without having public health having a seat at the table. 160 years ago, Florence Nightingale, fresh air from open windows is the only defense a true nurse either asks or needs. So we've known about this, the science is clear, yet we haven't done it. Right now, the world is rightly focused on ventilation and air quality as we think about this virus, and as we think about really half of healthy living, and that is disease avoidance. Disease avoidance is not health. Health is well-being, thriving, flourishing, and all of these other factors we call the 9 foundations of a healthy building that we know are linked to the scientific evidence on what drives better human health and performance indoors across all of these factors: lighting, acoustics, chemicals and materials we use that end up in the air and dust, and of course, basics like water quality.
So when we talk about the sort of the broad connections between health and place at the scale of the city and neighborhood, they roughly fall into 3 categories. One of which is exposures to sort of bad things like air pollution, problems with safety. Connections to the supports you need to live a healthy life, being able to access services in rural areas, access healthcare, issues like universal design. And then supporting you when you want to go and do healthy behavior, healthy eating, things that help your mental well-being and so on. And then they also differ by population, because a healthy environment for a child is very different can be very different to a healthy environment for an adult. So what I was interested in are the places which have kind of features that are thought to be health promoting and that have really been deliberately designed with sign of health promotion as an idea. And there are basically 3 kinds. There's a set of what I call classic healthy places, more comprehensive approaches. There are some that use population groups as a sort of central focus, and that's a way to build allies and really focus on on groups that are in need. And then there are some that I used to call the fake healthy places that use healthcare industries or technologies. But I've come to see that they're actually a richer set of options than I had thought. So I'm going to talk just briefly about a few of them. The first group, these classic healthy cities, do two main things. They have healthy built environments, all the parks and good housing and so on. But they protect you from these exposures. They connect you to the opportunities you need to be healthy, and they support healthy behaviors. But in doing that, they use what are called intersectoral collaborations or cross-sector collaborations to work between professions, business, education, government, and communities to bring a lot of different expertise and interests to bear. And it's that collaboration that's really the key to them actually making a difference. There can be narrower versions of this, like a cycling city, Houghton in the Netherlands is an example. But the broad ones, the best of the, say, World Health Organization, Healthy Cities programs, really are very comprehensive. The second group is the group that is population focused. And this group has been really increasing in numbers. And they typically focus on either older people or younger people and use their needs as a lens for improving cities and neighborhoods more generally. And I think politically, this has a lot of attraction. Now, although they might sound really similar, they're quite different in terms of their philosophy. So age-friendly cities, which are an idea and a WHO program, which has been around in this century, is based on health promotion like Healthy Cities, these multifaceted intersectoral collaborations. And they look at a lot of topics. As you can see on the left side, I have an example from a county in Canada, although one of the more famous versions is from New York. And China is about to push out 5,000 of these in the next few years to help with its aging populations. And what's useful about these is that they can really help focus attention on a group that everyone can kind of get behind. Child-friendly cities, in contrast, come from child development, so more out of sort of the educational side and psychology side. They're interested in the rights of the child. They can be collaborative. They're often, I'm an urban planner, so I wanted to focus on kind of the environment, and often they're more programmatic, but they do include, but children really inhabit the local environment so that they do place-based activities like these play areas. Finally, what I called health technology cities, and I wrote an article too about this, got published in just before COVID hit in early 2020. But these ones, there are two kind of basic ideas. One is using healthcare industry as a basis for a city, and there are a number of science cities that do this. And the other, probably with wider interest, is what I call smart health environments. And that's to make environmental technologies that can make cities healthier. I at first worried that it would just add gadgets to an existing area, but it can really capture the imagination, and there are ways that technology and sort of social interaction can combine to help with a healthy environment. My ideal would be to overlay these kind of technological gadgets on some of the more comprehensive approaches. I think there are 4 paths forward. It is quite possible that once we get through COVID-19, we'll have another roaring 20s and sort of try and forget it all. So that could, sort of not much may happen. It could be that we learn to prepare better, to do better public health surveillance, more robust early warning and quicker responses, the kinds of things that don't necessarily have to change an environment. What would be nice from my perspective, and I think from Joe's, would be what I call sectoral shifts, where there's some environmental changes, but probably in one sector, for instance, ventilation of buildings. There's been a lot of pop-up shared streets, these streets where cars are secondary to people, and many of them will stay, I think. And that could help health. Work from home will probably stay, although it's not so clear to me what the health implications are. There are some things I would like to happen, like better housing for lower income groups with more access to open space and just better quality housing. We've been trying to do that for years. I'm not sure it will happen. And then path 4 would be to really say we've been through this health crisis, and health is like super important and could be an organizing principle for thinking about things like resilient cities. So people have been trying to do healthy cities, sort of healthy versions of sustainable cities, healthy versions of resilient cities now for some decades. This might be the moment.